Welcome everyone. This session is going to be an important topic which is increasingly more recognized, ADHD in young people and adults. We have 4 guests attending online from Ireland. They'll share their Irish experience with us. Thank you for your participation to the Congress. Welcome to our guests. The first discussion is going to be about epidemiology of ADHD in adults attending Irish mental health services. We will listen this from Dimitrios Adamis. Over to you, please.
Hello, everybody. My name is Dr. Adamis Dimitrios. Thank you very much for inviting me to this conference and allow me to speak about one research that we have done in northwest of Ireland. It's about the epidemiology of ADHD in adult patients who attend outpatient clinics. I can show you the area here. Here is the area that we do this study. In the red is the Sligo County, and in the orange one is the Leitrim County area. Disclosure statements. I don't have any conflicts about this research and the presentation, similar the other co-authors as well and investigators. Now, a few things about the ADHD, although we have here in this conference a lot, just to remind a few simple things. ADHD is one neurodevelopmental disorder which starts from the childhood. It's often chronic disorder and very often persists into adult life. Some symptoms of hyperactivity and impulsivity may decline with age, but some others, like the lack of attention, continues unchanged. Similar symptoms of mood dysregulation, sleep disturbances, procrastination, and low frustration tolerance tend to persist and be worse during the adult life. General about the epidemiology of ADHD. Children and the young adult, the community prevalence, it was found that is between 2 to 7%, with one average around 5%. In adults, the community prevalence is between 2.5 and 5. One meta-analysis back to 2009 by Simon of 7 epidemiological studies found that the pool and prevalence of ADHD in adult population is about 2.5. However, this prevalence is very high when we in a selected population. For instance, one meta-analysis of 29 studies of adolescents and adults who attend substance use disorders, the prevalence was quite high, up to 23%. In psychiatric outpatient clinics, the previous study have shown one prevalence rate of 6.9 to 40%. The lowest was in Italy. It was Italia sample, and the other one was in Sweden. Now, the aims of the study that we start and we finish very recently, it was to estimate the prevalence of ADHD in those adults who attend the outpatient clinics in the Sligo-Leitrim area, to find out and to understand how many cases are diagnosed in this specific population, and to investigate as well the functionality of people with ADHD and the comorbidity of ADHD in this specific population. The inclusion-exclusion criteria. The inclusion criteria was all of those who attended the outpatient clinics to be between 18 and 65 years of age, to have minimum 5 years of education and able to speak, read, and write in English language. That was because some of the scales that we used was self-rating scales, so those people need to be able to read and to have some education to complete them. The exclusion criteria was people with severe learning disabilities, severe brain injuries, and amnestic disorders. The design of the study. We have two stages. The study is completed in 2 stages. The stage 1, we screen all those people who attended the outpatient clinics, and in the stage 2, those who has been screened positive for ADHD, we do further assessment and with more detailed further assessment. In the first stage, the screening stage, we use the scales, the adult ADHD self-report scale, which includes, has 18 questions. 6 of them, they are the most important questions about the symptoms of adult ADHD. This scale is based on DSM-4. We use the Weber-Utan rating scale, which is one retrospective rating scale of childhood ADHD symptoms, and has 61 or 20, there are 2 versions, one with 61 questions and one with 25 questions. Of course, we collect demographics and we look if the person has a diagnosis of ADHD in the file. In the second stage of the study, we use the Connors adult ADHD diagnostic interview, which is based on DSM-4 criteria. The mini international neuropsychiatric interview to look for the comorbidities, the global assessment on function, the GAF scale, to investigate and to see the function of each person. And those, again, who was scored positive in the screening stage, they have one psychiatric interview using the DSM-5 criteria. We also have some more scales there, but I'm not going to present them. It is the Millon's personality scale and quality of life. From the first stage, we approach about 822 patients. From them, some 760 was eligible. Some of them declined, some has been excluded because of the criteria that we have. And finally, the final sample which analyzed the first stage was 634 people. The criteria that we use for somebody to be positive of as a caseness, it was the WURS 25 to be more than 45. And if they have current depression to be 36, we lower the threshold. And the adult self-report scale, we use the version 6, if somebody has 4 or more positive symptoms. 4 or more symptoms for ADHD, we thought that it is positive. So as we use both of those criteria, so somebody who was positive in the WURS for childhood symptoms and positive for the current symptoms in adulthood, we thought that this case is perhaps positive for ADHD. From this first screening stage, we define as positive for further assessment for ADHD 131 people. It was about 21% of the sample. Looking at the files, we found only that only 3 had already diagnosed of ADHD. The study has been published 2 years ago in the Irish Journal of Psychological Medicine for somebody who needs to have some more information. And we are going to I'm going to present more now about the second phase of the study, the second stage. From 131 that we found positive with both scales, we managed to assess 110, about the 84% of the population. 21, they don't assess it. 11, we cannot contact them, and 10 declined to participate. Now, of the 110 participants, the half of them was males and the half females. The mean age was 35.9 and with minimum of 18 years to maximum to 62. According to the DSM-4 criteria, the Conn's scales, we find 71 that was they had been diagnosed with ADHD. Using the DSM-5 criteria, because the scale that we use, it was based on DSM-4 criteria, we convert the DSM-4 criteria to DSM-5 criteria. So using the same scale, but converting the DSM-4 criteria to DSM-5 criteria, we found that 89 people, around 81%, was can be diagnosed with ADHD. Using the clinical evaluation, using the clinical psychiatric interview, but again based on DSM-5 criteria, we found one number of 86 who were diagnosed with ADHD. Now, we have lost 21 people, they was not contactable. Looking at the data, we found that those 21 was completed missing at random, meaning that there was not any bias in the sample. So we were assuming that those 21 who did not has been assessed, they have the same rate of ADHD like the rest of the sample that has been assessed. So projecting the rates to the total sample, the 634 that we have initially investigated, we find the prevalence of ADHD in adult outpatient clinics, according to DSM-4, around 13.245%, with the confidence intervals 10 to 16. According to DSM-5 criteria, the prevalence was 16.72, with confidence interval between 14 and 20. And using the psychiatric clinical, in fact, evaluation, the prevalence was 16, with confidence interval 13.31 and nearly to 20. Regarding the comorbidity using the MINI, we found that most of the people with ADHD, significant more people with ADHD, have major depression or major recurrent depression by using any of the criteria. By using only the DSM-4 criteria, we have some kind of negative association between OCD and ADHD, meaning that people with ADHD has less often ADHD, but that was nearly significant. We don't find any other significant difference in the other comorbidities. Regarding the number of comorbidities, again, people with ADHD have more comorbidities than people with without ADHD, with any classification system. So people with ADHD was, the number of concurrent diagnoses was significantly more than those with without ADHD. Regarding the functionality, the overall sample was quite dysfunction, with low function. It was about 60 out of 100. And again, those with ADHD had lower GAF scores, meaning worse functionality, compared to the other without ADHD. And that was quite surprising result, because the rest of the people was quite with severe and enduring mental illness and chronic mental illness like schizophrenia, bipolar, and this kind of diagnostic categories. The power of the study was quite good. It was 79%, nearly 80%. So what we can conclude from from this study? There's one high prevalence of ADHD cases in adult mental health services. Most of the cases continue to be symptomatic in adulthood. We have identified only 3 cases which already has been diagnosed with ADHD, which is a very low number. There is higher degree of comorbidity among those with ADHD compared to those without ADHD. Those with ADHD are the most impaired in terms of functionality compared with non-ADHD outpatients, which I say the majority of the outpatients, it was people diagnosed with severe mental illness. And another kind of surprise, but very small number of 6 people have only symptoms during their adulthood. There is, this means that, or maybe it was kind of a recall bias, they don't remember very well when we ask them, although we try in every case to have collateral history. Perhaps there are overlaps of symptoms between ADHD and other mental disorders during the adulthood, but as well there is a notion of late onset of ADHD. Although the first criteria of DSM-4 and previously have one limit of age of 7, after the DSM-5 increased to 12, there is kind of ongoing debate that perhaps ADHD can be later as well presented in the adulthood life when some environmental or other factors, or perhaps genetic as well, can make the people to express the symptomatology because of difficulties, environmental difficulties, or kind of higher demanding of their jobs or what they're doing. Anyway, that's something, very small number for us to have some conclusion of that, but it's one ongoing debate. So the other thing that we found, but that is quite common, has been in the literature now, that when you use the DSM-5 criteria, the prevalence of ADHD is going higher. That's because the DSM-5 criteria is more inclusive compared to DSM-4. First of all, because they increase the age of onset, so there are more people that can be diagnosed with ADHD, which they develop the symptoms or they manifestate the symptoms after the age of 7. And of course, the reduction of a number of symptoms in DSM-5 from 6 to 5 in this examined group, because allows, if somebody is age 17 and above, to be diagnosed with 5 out of a stand of 6 symptoms. This diagnostic requirement theoretically can increase the number of cases, and especially those who are in the sub-thresholds between 6 or 5 or 4. That's quite common as well, the 5. Some of the researchers and clinicians are they support this kind of reduction of symptoms because that's perhaps in this age reflect the real clinical reality. Some others still they argue that by doing that we overdiagnose people with ADHD. Now there are some limitations of the study which are quite important. The study is only in one area of Ireland, so supposedly that reflects only this area, since there is not any randomization around the island. However, looking in other countries and other similar research, we are quite confident that the numbers that we found, it's around the real estimation of the population who have ADHD in the outpatient clinics. Now, the other thing is because we don't investigate people who was negative at the first stage, those who was perhaps false negative. perhaps the estimation that we give from this study, and it is kind of more conservative. Maybe more people can have ADHD than we estimate. However, because of financial and difficulties, the restrictions that we have, we cannot do that to examine some people who perhaps have was negative, but perhaps they have false negative symptoms. So that is about the study, and just take-home message from this study is that there is one substantial rate of adult ADHD in the psychiatric outpatient clinics, which from them the majority is going unrecognized. There's a high degree of comorbidity among those with ADHD compared to the other outpatients without ADHD. And as well, they are most impaired in terms of functionality compared with the non-ADHD outpatients. Given that to treat other comorbidities is more difficult if the ADHD, the core diagnosis is untreated, the most important thing is that the people in general psychiatrists actually, they need to be aware that 1 out of 6 of their patients maybe they have ADHD. Here is some reference, and here's as well one thank you to collaborators. A lot of people they have been involved in this work. And thank you again, everybody, for your attention.
Thank you, Dr. Ademus, for presenting the results of your research, which really highlights the missed diagnosis of ADHD in adult outpatients. Very interesting, in fact. And the next speaker is Dr. Margot Wrigley, who is going to talk about National Clinical Program for Adults with ADHD in Ireland, Model of Care with Early Implementation Update.
Good afternoon. My name is Margot Wrigley, and I'm presenting to you today the National Clinical Programme for Adults with ADHD in Ireland. What I'm going to talk to you about is why we set up a model of care, how we designed it, and an update on early implementation. I'd like to acknowledge my co-workers, Fiona O'Riordan, who's Programme Manager, and Amir Niazi, who's the National Clinical Advisor for Mental Health in Ireland. None of us have any declarations of interest to make. So we decided that ADHD should be a clinical program for a number of reasons. They include, first of all, that ADHD is a very common neurodevelopmental disorder occurring in 5 to 7% of children. And it's now known very clearly that in adults, the full syndrome occurs in 1.5% of adults. It's also known that the symptoms are very similar to those in children. So, for instance, they're the 3 core symptoms of inattention, hyperactivity, and impulsivity. There are also similar impairments of functional domains, similar patterns of comorbidity, particularly anxiety and depression. It also responds to stimulant medication in adults, and there are also similar cognitive performance measures noted. It's also now very well known that unrecognized and untreated ADHD in adults leads to not only the distress of core symptoms on the person and on others, including their families, but also a very impaired ability to function at work and in academic settings. Relationship problems are very common indeed and related to volatility of the mood, antisocial behavior, and there's also noted drug and alcohol misuse. Looking at the Scandinavian studies, they found an increased rate of road traffic accidents and also of criminality in prison populations of up to 25% of those who are imprisoned. In the public service in Ireland, children receive a service through the child and adolescent mental health teams, of which there are 68 distributed nationally, but there's nothing available for adults. And so the HSE, which is our National Health Service, identified this as a crucial clinical gap. I was appointed as clinical lead and asked to set up a working group. This was multidisciplinary in nature, and service user input was absolutely crucial. And I would like formally to thank ADHD in Ireland for nominating one of their members who has ADHD to this group. So we worked on the model of care for over a year, and it was completed in April 2018. As with all our clinical programs in Ireland, it then went to our body, the College of Psychiatrists of Ireland, who set up a clinical advisory group to consider the draft model of care. And they considered it over a period of time and determined it was in line with best evidence-based clinical practice. So that meant it was totally approved and then went through the formal approval process by the HSE. So I'd like to say a little bit now about the impact on adults of the various symptoms. So whilst they're, as I've said, they're the same symptoms as in younger people, they do present a little differently in terms of behaviour. So the inattention in adults presents as forgetfulness and being very disorganised. The hyperactivity can present as excess talking rather than excess physical activity, and the impulsivity as butting into others' conversations, never letting them finish a sentence. To make the formal diagnosis, there's a requirement to have a functional impairment in two or more domains, and these include work and occupation, leisure or recreation, social interactions, relationships, managing money, and of course driving and defending behaviour. There are another set of symptoms that are described as non-core, but when you talk to people with ADHD, they will tell you they cause just as much problems, in fact, sometimes more so than what are called the core symptoms. And they are procrastination, that's very great difficulty in starting anything, having a very low frustration level and losing temper rapidly, mood lability, needless worrying, even though the person themselves know that there's really absolutely no need to worry. Low self-esteem is almost endemic. Mind wandering, which is automatic mind wandering, even if a person has made a determined decision that they're going to concentrate on something, they find that their mind just wanders off. And that's very, very frustrating. And insomnia is extremely common, particularly in initial phase insomnia related to delayed excretion of melatonin at night. And that in turn leads to an inability to get up and set about one's business in the morning. So they are really very troublesome symptoms for adults who have ADHD. But in our clinical program, we were equally keen to emphasize that there are a lot of positive aspects to ADHD as well. And the sort of things that have been identified and spoken about are creativity, being able to really focus on something if one is really interested in, and that can be extremely important for project work. Persistence is also key. Being able to react quickly. So for working in certain emergency services, someone with ADHD really does a very good job. Lateral thinking is also noted. So for most of us, who can't come up with a solution with the problem, someone with ADHD may be able to just suddenly come up with something off center that is the whole solution to the problem, and that's a really positive skill too. And finally, most people who reach adulthood with ADHD have found themselves subject to a lot of criticism, and that makes them very sensitive to other people's pain as well. So and that again can be very positive. And in this picture here, I show you some well-known people to most of you with ADHD. So Richard Branson, Michael Phelps in particular, who's the athlete with the greatest number of Olympic gold medals. And we in Ireland have our very own Helen Steele. She's the lady with the blonde hair and the multicolour coat, who's a very well-known artist and clothes designer. So one of the seminal papers that we very much took to heart in considering the model of care was a European consensus statement by Cooge that was published in 2010 on the diagnosis and treatment of ADHD in 18 countries in Europe. And the main findings from this study were that it is an impairing lifelong condition which is underdiagnosed in most EU countries. It impairs quality of life, and it results in ongoing distress and impairment. And it also showed that there's over a longer term that people have a decrease in their number of close friends and relationships. There's an increase in academic failure, overall lower occupational status. There's an increased rate of substance misuse, and I've already said an increased rate in road traffic accidents and in offending behaviour. But what was very striking in this paper was that not only was there a huge stigma against people, adults in particular with ADHD, by the general public, but also amongst professionals, including those working in mental health services who can be very dismissive about the existence of ADHD. So looking at our own situation in Ireland, there were a couple of early studies done that showed when screening was carried out for ADHD symptoms in adult attenders of mental health services, that between one quarter and 1/5 screened positive for ADHD symptoms. And my colleague Demetrius Adamas has, just before me, presented to you his findings, which are very important in terms of making a very clear case that ADHD in adults does exist in Ireland and does need a response. So as I said, there were virtually no services in place apart from Demetrius's services covering Sligo Leitrim of 1 session per week, which developed from his own research interests and had no additional resources. So coming into the detail of the model of care, looking at the clinical components and reviewing what was available, we determined that the assessments should be based on the DIVA-5 now. That is the diagnostic interview for adult ADHD, that it was important to identify comorbidities as part of the assessment, to identify functional impairments, and a collateral history was also essential where available. Very much in line with the NICE documents on managing and diagnosing ADHD, we emphasise the importance of a post-assessment discussion whether ADHD was diagnosed or not. For those without ADHD, it's very important they hear why they are not thought to have ADHD, even though they might have thought they had it, and for them to be signposted in the correct direction. And likewise, for those with ADHD, we need to have a good discussion with them about ADHD, why they have ADHD, how it's impacting on them, to affirm the sort of distress they've had from their symptoms over the years and give them some hope in terms of the interventions that we hope to be able to provide for them if they're happy to proceed with interventions. So the next stage of the clinical aspects of the model of care are the interventions recommended, and the specific ones that we recommended would be provided through the health service are ADHD specific medications, obviously the stimulant medications, methylphenidate and lisdexamfetamine, but also atomoxetine and 1 or 2 others were indicated. Psychoeducation, terribly important. ADHD-specific cognitive behaviour therapy, and practical interventions delivered by occupational therapy. Equally, we felt it was very important that people accessed other interventions that weren't directly provided by the HSE, and in particular, we're very keen that they would link into voluntary organisations, in particular ADHD Ireland, which provides a wealth of information, of support and education. They do provide, for instance, support groups for adults with ADHD. We also signpost them to ADHD-specific coaching, suggest third-level educational supports where people are attending third-level education, and where they're trying to find a job or trying to keep a job and they're having difficulty, we recommend they link into employability, which is part of the Department of Education function in Ireland. The next item that we considered was what sort of service model we should recommend. And in considering this, we were fortunate in that UCAN over the course of 2 years, had investigated and presented at their annual conferences a number of service models. We also looked at the ones that are available in Europe and elsewhere. And the service models that we identified were those delivered by primary care, a national tertiary care model, a secondary care local model, combined secondary and tertiary care mental health model, or just through secondary care, i.e. general adult psychiatry services. And when determining which ones were the most, which if any would be the best, we looked at the quality of assessment provided, quality of non-pharmacological interventions, pharmacological interventions, the referral pathway, the waiting list, and some of them were extraordinarily long with 2+ years, not being unusual, a continuity of care for people with ADHD, the ability to ensure treatment of comorbid mental illness, including access to inpatient care, the monitoring of medication, throughput, training, the provision of training, and sustainability of the model. And in the end, the model that that came up best, really, to in all of the ones we considered, was a combined secondary and tertiary care model. And I'll say a bit more of that when I'm going through the clinical pathway. We then looked at the service structure, and we determined that we should provide an adult ADHD clinic team for every 300,000 to 400,000 working age population, that a team would consist of a consultant general adult psychiatrist, a mental health nurse at clinical nurse specialist level, so quite a senior nurse, a senior psychologist, and a senior occupational therapist. And absolutely essential is an administrator to the service. We also considered it important to collect activity data, both on throughput but also outcome, and on opinion of those who use the service. So we devised data to try and capture all of that. The next thing was to look at the distribution of clinics nationally. So in Ireland we have 26 counties, so they're listed in that table. And we looked at the adult population between 18 and 64. And based on the distribution that I spoke of before, we determined the number of teams, as I've shown you there, so 11 in all. And we also looked at prisons. And whilst we felt in most part of the country, the local team could provide some support and input to their local prison, what we did notice was that, and we're all aware of, is that there's a huge concentration of prisons in the Dublin area specifically. You can see them listed there on the right-hand side. So we decided that we should also recommend the provision of a specific ADHD team for adults to work alongside the forensic mental health, community mental health teams. They in-reach to the prisons in Dublin are very active. So those are the total number of teams. This is the clinical pathway I mentioned to you earlier. So in brief, what this means is that a person who suspects they have ADHD goes to their GP, or indeed the GP may suspect in someone who's presenting to them with difficulties in managing life in particular, that they may have ADHD. They would refer them to their local general adult mental health service, and services have precise catchment areas in Ireland, so it's precisely known who you'd be sent to see. The services carry out a full mental state assessment to make sure that they're not dealing with a significant mental illness. They also would ask the patient to carry out 2 screening tests. The ARS, which the adults screening test for ADHD, which picks up current symptoms of ADHD, and the Wender-Utah rating scale, or the WERS, which identifies whether there were symptoms present in childhood. And if the person scores positive in both of those, they are then referred on by the general adult team to the ADHD clinic. They then carry out the detailed assessment I've already outlined to you. They have the post-assessment discussion. They deliver the multimodal treatments. And then if people are on medication, at the end of the completion of treatment, multimodal treatment, they will then discharge them to their GP, and unless there's a particular reason for them to also link back into the general adult service, for instance, if they have a major mood disorder, but they're discharged back to the GP, and then in line with the NICE recommendations, they're recalled on an annual basis to see do they meet the criteria, do they still need to be on their medication. So that's the support for GPs and good practice in terms of the prescribing of this medication for people with ADHD. If they've completed the multimodal treatments but aren't on ADHD specific medication, they're just discharged directly back to their GPs with no specific follow-up unless they run into difficulties again. We have a modified pathway for young people who attend the child and adolescent mental health services and are being seen and treated by them for ADHD. So their 17th birthday, we ask that the child and adolescent mental health team reconfirms the diagnosis of ADHD and whether they need to continue to be seen after the age of 18 by mental health services. That one of the members of the team is appointed a transition lead for that particular young person, and they liaise with both the secondary care mental health service and the adult ADHD clinic, and depending on the child or the young person's particular problems, whether mental illness or ADHD is the primary problem, they are then at the age of 18 passed on to the relevant service. So they don't go through an adult service to get to the ADHD clinic, but rather they can go directly through this modified pathway, so it simplifies matters for them. So a word about implementation so far. As you know, with any of these service initiatives, it remains a report unless funding is allocated. And we were fortunate that we were allocated €1.3 million to start the implementation of this national clinical program. We estimate we'll need 5.5 million for overall national implementation. So in 2019, we started, which is when we got the full allocation of the money, we identified 3 demonstration sites. And we were able to put in place a half-time consultant in one of the sites. So only half the area could be covered. But the full-time adult, general adult post is currently advertised, so we hope to be able to extend that into covering the full area in early 2022. The second site started in January of this year, and the third site is due to start at the very end of November of this year as well. So we'll have all 3 demonstration sites up and running, hopefully in very short order. So the other updates I'd like to give you is that we've also developed DIVA assessment guidelines for the multidisciplinary team, in particular for psychology and nursing members of the team. We've had some very good collaborative work with our partners, ADHD in Ireland and the UCD School of Psychology, that's University College Dublin's School of Psychology, on an ADHD app and on a workshop development called Understanding and Managing Adult ADHD, or UMAP, and you'll be hearing about those 2 initiatives straight after my talk, so I won't say too much about them. We've also been awarded a research grant to study suicidality. This is part of our collaboration with ADHD Ireland and UCD School of Psychology, I should clarify, to study suicidality and self-harm in adults with ADHD. And that's underway now, data is being collected. And then finally, we felt it was really important that with the new clinical program, and this is our rule with clinical programs in Ireland, that we do an evaluation of the clinical program, and UCD School of Psychology, excuse me, are going to do that for us. So 2022, well, from early on this year, we started to look for more funding so we could develop more sites next year. And we've just heard at the beginning of October that we are likely to get 1.8 million allocated by the Department of Health. And if that happens, we should be able to set up 3.5 adult ADHD clinic sites next year. I've written down there the 3 sites that we're looking at, and the 3 full teams are where you have the full population, and then Kerry and West Cork, it's about half the population of the other 3 sites. That's why they've got a half team, a bit like Sligo, Leitrim, Donegal. So that'll be a large part of our work in terms of recruiting those teams, educating those teams, etc. For next year. And hopefully by the end of next year, if I was talking to you again, I'd be able to tell you that we have 6 of the 11 areas that I spoke to you about at the beginning covered. And we are obviously from about probably Q2 onwards of 2020 we'll be starting to look for funding to cover some of the remaining 5 areas. So thank you very much for your attention. If you're interested in looking at the model of care, and that's the front cover of it, that's the link on the HSE website, and you're very welcome to look at it. Thank you very much indeed.
Thank you, Dr. Wrigley, for sharing your new service model with us. It's really inspiring and interesting. Thanks again. And the next speaker is Dr. Christina Sherry, who is going to talk about development of a psychoeducation and self-help app for adults with ADHD in Ireland.
Good afternoon, everybody. It's a real pleasure to be with you all for the 12th International Congress of Psychopharmacology. My name is Christina. I'm a PhD candidate in the UCD School of Psychology, and today I'm going to be talking about the development of a psychoeducation app for adults with ADHD in Ireland. I'd like to thank Margot Wrigley for the invitation to speak today. And this research is conducted with the School of Psychology in UCD, with ADHD Ireland and the HSE National Clinical Programme for ADHD in Adults. And my research is funded by the Irish Research Council Government of Ireland Scholarship. Okay. Sorry. So just to start us off, I'd like to show this quote from a paper by Hansen Hellerode et al. In 2015. So the participants said it was almost like things got better just from knowing that it was ADHD. And I wanted to start with this quote just to really show the impact education and knowledge of ADHD has, particularly in adapting to an adult ADHD diagnosis. So there have been multiple qualitative studies that have shown this emotional roller coaster of the journey that it is to adapt to a diagnosis of ADHD in adulthood. I just wanted to really capture that with a diagram. So there's a lot going on here because there's a lot of change and a massive identity shift after being diagnosed with adult ADHD. So what research has shown and captured is that there's often this emotional reaction at the beginning. So it can be a strong sense of relief to finally have an answer. This person might have had a lifetime of really struggling without ever knowing why, so they can finally understand and have an explanation. But on the other hand, there might be a lot of doubt or questioning the validity of that diagnosis, particularly if they have quite a stigmatized view of ADHD or a stereotypical view of ADHD. If they don't have the understanding that it can last till adulthood, that might be extremely confusing. So from there, people can experience turmoil and confusion, and there is this kind of sub-process here of emotional processing. But typically after they adapt to the emotional reaction, they might feel turmoil and confusion. Once they start to understand ADHD and you start it on their acceptance towards it, there is a sense of grieving a late diagnosis. So grieving lost opportunities because it wasn't picked up by somebody sooner in life. But from there, there's this interest in ADHD So starting to seek out information about it, and also starting to share information about it, teaching other people about it. And from there we have an identity shift. That can be positive or negative, very much depending on their experiences. So they might, in a positive identity shift, the person might start to understand themselves better, have an increased sense of value, and start to notice positive change in how other people perceive them. Their families, their partners, their friends might be starting to be less judgmental and treating them with more compassion. On the other hand, somebody might be having quite a negative identity shift. So you might be very aware of stigma. There could be situations at work where they've told a boss about ADHD and been rejected for it, or they might have had people in their lives disagree with the diagnosis. They could have a sense of decreased value, so that self-esteem is having a negative, or the diagnosis is having a negative effect on their self-esteem. They might be questioning their identity and still concerned about that ADHD diagnosis. But from there, there's an adaptation to the diagnosis. So changing how they live, positively or negatively. So in positive change, there's a perception of the diagnosis changing life for the better. They might start seeking help from other people, professionals, friends, other adults with ADHD, and they might start seeking out self-management tools to learn how to help themselves. On the other hand, there can be this real strong sense of fatalism, so the perception that the diagnosis is limiting life, that it's cut out opportunities for them, that they're unable to seek help perhaps because there's not enough services available, that the diagnosis is a negative self-fulfilling prophecy, and that they fear of discrimination, and they continue to either grieve getting the diagnosis, grieve having the diagnosis at all, or that continued sense of not being diagnosed sooner and missing out. But hopefully then that change does lead to acceptance of the diagnosis. What I really want to highlight here is that psychoeducation plays a massive role in this experience of receiving a diagnosis of ADHD in adulthood. So psychoeducation has been recommended as the first step in multimodal care after a diagnosis of ADHD. It's in the NICE guidelines for interventions for ADHD, but by providing quality psychoeducation at an early stage post-diagnosis, whereas the person is starting to learn about their ADHD and really seek out that information after this emotional reaction, we can hopefully really start to ease them into it and create this positive identity shift and positive change so that they can live meaningfully and see this as a positive development in life, and hopefully a helpful one. So we know that psychoeducation for adult ADHD is highly effective. A lot of the studies have been group-based psychoeducation, and we've seen some pre and post studies, some comparison studies. Gavrakowski et al. Did psychoeducation for adults with ADHD and their partners, and they did an RCT of that. And so a lot of different measures have been shown to be improved by psychoeducation. Knowledge of ADHD, self-efficacy, self-esteem, well-being symptoms like depression, anxiety, and ADHD symptoms of inattention and impulsivity have been improved as well. So given that we know that it's effective, we're proposing that there are other ways beyond just group interventions to give out education or share psychoeducation. So digital health technology like smartphone apps, websites, but particularly smartphone apps in this instance, can be a helpful tool for adults with ADHD and a really useful medium for psychoeducation. So in terms of adult ADHD, apps in general are massive tool for organizational strategies. It can provide digital diaries, itineraries, lists, reminder notes. But as a medium for psychoeducation, apps offer individuals with ADHD an opportunity to read material, come back to it, think about it, question it, really identify what they relate to and what they would like support in over their own time. So that immediate post-diagnosis discussion might feel a little bit overwhelming, or they might not be picking up on everything, whereas an app will allow somebody to come back and really let it sink in. And then from a practitioner's side of view, psychoeducation app will be cost effective. It can cover a wide array of topics. So you can really use an app to cover all your bases and not just the kind of main points that are super important to hammer home in psychoeducation groups or psychoeducation, immediate one-to-one psychoeducation. But unfortunately, there's very limited research on digital health technologies or psychoeducation apps for adults with ADHD. So of the research that's there, there's a focus on children and young people. But a systematic review of apps for ADHD in the App Store and Marketplace that was published last year showed that only one of those apps had been empirically evaluated, and only 16 of those apps noted that what they were using or their content was based on empirical research. So that's a cause for concern as well. We want to make sure that the apps that are being put out are quality, research-based, and giving people the right information. But a recent pilot of a smartphone CBT chat box found that after 4 weeks of use, symptoms of inattention and emotional ability were lowered in comparison to a control group. Although this pilot was done with patients with inattention symptoms, not just adult ADHD, but they measured ADHD using DSM for ADHD symptoms, which is a little bit outdated. But what they did find was that greater engagement with psychoeducational content. So there was different sections of this chatbot. So there was the CBT side, there was like mindfulness pages, and then there was psychoeducation about inattention. So engaging, the more engaged people were with that psychoeducational content, the lower their measured ADHD symptoms were. So it shows promise as a concept, but very, very early on in that stage. Like the research is just so limited yet. And then on top of that limited research, the challenges of apps is that they have a really high rate of attrition. So, a study in 2018 by Hidalgo Mejia et al. Found that only 30% of their original 201 participants were still using the app after 6 months. Even though it was proving at their different stages the app was effective, it just was losing participants the whole time. So one of the ways we can overcome these barriers is by engaging the service user perspective at a very early stage. So recommendations for frameworks of evaluating apps show that we should be including service users at every stage of the evaluation and development. And this is one of the ways we can overcome this issue and address attrition, making sure that we're not just prescribing what we think would be useful, making sure that we're meeting the needs of the people who will be using these apps. And so using that service user including that service user perspective is in line with the HSC National Clinical Program for ADHD, in line with their values. So on multiple levels, we're doing it from a research point of view, by including these perspectives. We're hoping to address engagement barriers, and then also we're meeting those core values and making sure that at the heart of what we're doing, we are including service user perspectives, so including the expert by experience view. So the overall aim of the present study is to develop a psychoeducation smartphone app for the HSC National Clinical Program by including the views of adults with ADHD through employing a Delphi consensus method. Our specific objectives were to identify what adults with ADHD want to know about their condition and develop appropriate psychoeducational content based off of that, and then identify what adaptations adults with ADHD want to the presentation of app material. So how big the text size should be, if they want videos, how useful audio clips are. So the Delphi method aims to converge opinions of experts. So in this case, experts by experience or adults with ADHD. Sometimes you get healthcare, or a lot of the times with Delphi methods, you get a panel of healthcare professionals. So we'd use structured rounds, conducted a view questionnaire, and at each round, participants receive feedback. So they see what their response was originally, and then what the overall group average was, so that they can adjust according to that. And we analysed these responses using interquartile ranges. So that measures the variance. So a score of 0 to 1 means there's very, very little of variance, and that consensus has been achieved. So firstly, we started off by conducting thematic analysis on different organizations for ADHD's websites to get a sense of what topics they're providing at psychoeducation on their websites, because we wanted to reduce participant burden by creating a big long list that they could tick off and then suggest on top of that, rather than doing an open-ended survey where they pop in all their suggestions, just to make it a bit easier. Initially, we had 43 participants with ADHD, so participants ranked a list of 119 topics from a scale of should not be included to essential. There was consensus was achieved on 94% of these topics. About 112 topics had an IQR of 0 to 1, so that means they achieved consensus. And then participants suggested an additional 37 topics that went on to round 2. And the app presentation suggestions all achieved high consensus as well. And so we had a bit of attrition between rounds of 44%. But we had high consensus on all of them, except for gender ratio, which achieved an IQR of 2, which is still pretty close. But there was still just a tiny bit of variance. Other than that, there was a high consensus achieved. So what we found was that there was a massive diversity in the psychoeducational needs of adults. So they wanted to know about a wide range of topics. So from, about what ADHD is, so executive functioning, core types, how to use it to your advantage, and then the core symptoms, and the psychosocial factors behind ADHD as well. And they wanted to know about how to get a diagnosis, what the process is like, how to know if you need a diagnosis, what the impact of undiagnosed ADHD is. In terms of interventions, people wanted to know about finding a professional, how they could do that, all the intervention options available. So there wasn't just a focus on medication. People thought it was essential to be learning about psychological stress, relaxation and stress management, parent training, and occupational therapy. Also a massive need to know about how to live with ADHD. So different pages for mental health, relationships, work and education, finances, and also legal rights. So how are they protected by law? And so in terms of app presentation preferences, graphics were essential. Text and videos were important. There was an opportunity to provide additional suggestions for adaptations. And one of the most common was that text needed to be very short, used in bullet point format, and avoiding long paragraphs. And then participants were also unsure about the use of audio clips. So not convinced that it was needed, that the text and graphics were far more important. So we're applying this now to the development of a psychoeducation smartphone app. So the way we've gone about it is a balance between psychoeducation, so learning about these different aspects, and also what can I do about it? So with some self-help tips for moving forward. So you can see here, this is what the main page will look like, or the index on the main page. So we have a My Planner section where people can pop in goals, a bit about the ADHD clinics and the HSE, some news, how to use the app, assessments and interventions, about ADHD, self-help techniques, and how to live with ADHD. And so given the importance, or that graphics were considered essential, we've also been doing some illustrations for these, just to try and make the app more dynamic. So these will be limited to certain pages, like about ADHD and living with ADHD, to keep the sections on the ADHD clinics nice and clean, and also to make sure that we're not downplaying the importance of interventions and just keeping that nice and professional. So just in terms of implications for yourselves, so you can use these findings to structure post-diagnosis discussions, so making sure to be mindful of neurodiversity or affirmative approaches, and how that negative identity and negative change can emerge. So making sure to focus on the advantages and not make sure it's being mindful of a deficit-based discussion and trying to avoid that. So thinking about discussing what is ADHD, what are all the intervention options, what is it like to live with ADHD, and what supports are available or self-help management tools for navigating day-to-day life. And so the key aspect here is to make sure you're incorporating visuals to help that process and to help engagement with psychoeducation. And then in terms of the development of psychoeducational materials, our findings can inform leaflets, websites, etc. for adults with ADHD and their partners and families. A good few studies have recommended to engage partners and families in psychoeducation. And then so that support system is built in to help that person continue to use those self-management strategies and to develop understanding so that others receive them with more compassion. And so just a note on limitations. So our topics were derived from thematic analysis of organizations' websites. The language was the language in the topics list that we used in the Delphi method was based on that website content. So we took that language directly, but it might have been overly medical. So for example, we used the term comorbidities, and we've now shifted to co-occurring conditions. And we also used the term transitioning from CAMS to adult services. And again, that acronym was used on those websites. It would have been clearer to use child and adult mental health services. We also removed some topics from round 1 to round 2. So 3 topics were not included in the second round. So these topics were notifying the Road Safety Authority, driving insurance, and weight management. The driving topics came from 2 different websites in 2 different countries, but upon some research in terms of the need of the driving, it's not necessary in Ireland, so we removed those to minimise confusion. And weight management was removed to avoid redundancy because nutrition and exercise were both rated as essential in the first round anyways. So thank you so much for listening to me. I hope you found it informative. You can feel free to contact me on my Twitter or by email. And I'd just like to thank again, ADHD Ireland and the HSE National Clinical Programme for all their support in this research. And you can just scan this QR code for the bibliography. Thank you very much and have a good day.
Thank you, Christiana, for your presentation. It sounds like a big help for newly diagnosed adults. Very interesting. I think we can now move on to the last speaker, Jessica Bram, who is going to talk about understanding and managing adult ADHD program, psychoeducation, and self-help workshops for adults with ADHD.
Hello, my name is Jessica Bramham. I am Professor of Clinical Neuropsychology in University College Dublin School of Psychology. I have been collaborating on this project with my PhD student, Christina Seary, who I really need to acknowledge in this presentation because she has done a huge amount of work in preparing the materials and devising this program. So big thanks to Christina. My other collaborators are Dr. Margot Wrigley and Fiona O'Riordan, who are the clinical lead and the programme manager for the Health Service Executive in Ireland's National Clinical Programme for Adults with ADHD. Margot has already given a presentation about the model of care for Ireland, and she and Fiona have been the driving force behind the development of the Understanding and Managing Adult ADHD programme that I'm going to be describing today. And I'd also like to acknowledge Ken Kilbride, who's the CEO of ADHD Ireland, who are our charity partner, who will be rolling out the delivery of this programme in the future and have been hugely supportive in terms of the development and helping with service user involvement and experts by experience for consultation. So thank you to all of the collaborators. It really has been a team effort here. So I want to tell you about our new programme, which is called the Understanding and Managing Adult ADHD programme, the UMAP. And the reason that we've developed it there's a few reasons behind it. One is that until very recently, there has been very few services that offer anything for adults with ADHD in Ireland. And this kind of fills a gap that allows people to have something in the meantime while they're waiting for services, but also to supplement the services that are there. We know already that whilst many adults with ADHD do benefit from medication, they also benefit from other interventions, including particularly psychoeducation, learning more about ADHD and the way it affects them, and also from different types of psychological intervention. Another aspect of from working with adults with ADHD over many years, I've noticed that peer support provides a hugely therapeutic role for their journey in adjusting to the diagnosis, and learning from each other is almost as important as gaining the skills from clinicians. We're looking at developing psychoeducational groups, capitalising on the fact that people do benefit from working in groups and learning from each other, and also that there has been demonstrated efficacy for psychoeducation groups for increasing knowledge, but also improving psychological well-being and self-esteem. So with that in mind, in conjunction with the charity ADHD Ireland from the voluntary sector, we have developed this programme, the Understanding and Managing Adult ADHD programme. And it's for people who have been diagnosed with ADHD, people who've had long-standing diagnoses, people who've self-diagnosed that they maybe have a child with ADHD and they recognise the symptoms in themselves. They may not fully meet criteria for ADHD, but they have symptoms that they want to do something about. So this is for many people beyond those who are already receiving services. And our aims are firstly to increase understanding about ADHD, to allow people to learn something about the disorder, the way that it's affecting them, and then to provide a range of skills and techniques to help them manage. And I suppose one of the ideas is that we're providing lots of different suggestions, and it may be trial and error that allows people to find what works really well for them, but we're trying to offer as many options as possible, with a view overall to kind of help with people's self-esteem and improve their quality of life through managing their ADHD symptoms better. So there's two real components to this programme. The first is psychoeducation. We're trying to pack as much information in as we can to allow people to kind of understand their challenges and also gain expertise in their own ADHD. Not everybody's the same. So really kind of get to grips with what is affecting them. And then we're basing the self-help materials on ACT, which is a third wave CBT model called acceptance and commitment therapy. And the kind of idea behind this is that it's a therapeutic approach which has stems from behavioural therapies, but it aims to modify how somebody relates and responds to their inner experiences, such as thoughts and emotions, and particularly urges and impulses in ADHD, in order to allow them to live in a way that is particularly meaningful for them. So we explore that in some detail, what it is, the life that they want to lead and how to get there. The topics that we are going to cover in our programme are, first of all, a kind of introduction to what the programme involves and gaining some momentum for change. The second session is much more about the particular issues in ADHD, what inattention is and what to do about it, as well as impulsivity. The third session is much more sort of practical daily life skills and managing ADHD in the workplace and in educational settings. Then the fourth session is much more about emotions and how ADHD can affect those, and mood regulation and suggestions of techniques to use there. And then finally, it's about pulling everything together and making plans for the future and accepting ADHD, accepting the challenges that it brings, but also recognising the benefits of it and ways in which somebody can thrive with ADHD. So the pandemic actually has been advantageous in this regard. We had intended to deliver this face-to-face, but now it seems much more sensible to use a webinar format and do it online, which will allow a lot more people to attend, and geography poses no problems then. People don't have to find childcare or leave work to be able to attend. We're doing 5 1-hour only workshops. We thought any longer would be difficult for people to concentrate, and we're going to do it in the evenings so that people are hopefully going to be more available. It's going to be different from a group therapy in that we're not necessarily asking people to go around the room and share their experiences and so on. What we're looking for is people to be able to share things that they want to share in the chat and make suggestions for other people. But the bulk of the materials will be delivered by us and offered in a workshop, in a workbook as well. We're going to be using the Pomodoro technique, which is breaking things up into shorter chunks. And even within the 25 minutes that we're delivering the materials, we're breaking it up even more with lots of short extracts of different, with different strategies. And I'll explain a bit more in a minute. And we'll obviously have breaks because that will allow people to concentrate better. Alongside the webinars, we have developed a companion workbook which gives summaries of what we have covered in that particular session, and also it allows people to do some of the exercises while we're in the webinar. But we've tried to kind of capture a lot of the materials there so they can use it again in the future and show it to other people if they would like to. We obviously have to have certain ground rules. Again, I mean, it isn't a group therapy, but there are privacy issues that people need to be aware of. So not disclosing things that they wouldn't want to share in the chat, but also respecting other people that they don't want to be broadcasting information that they've seen in the chat either. And we're also being careful about, not responding to individual questions about clinicians and so on, because that's inappropriate in this format. So we've decided that given the neurodiversity movement and neuroaffirmative movement that is happening across the world at the moment, we've decided to take the approach of neurodivergence, acknowledging that people have these characteristics and traits that are often regarded as symptoms, but they're not necessarily disadvantageous for everybody. And we try and focus on some of the strengths that people have with ADHD and reframing some of the challenges in terms of what the benefits are. Recognizing that some people with ADHD say that they wouldn't give it up for the world. I mean, it really does advantage them, but it's making sure that the environment around them works well for them, and also being being motivated to work in the area that they're working and with the people that they are working. So it's kind of acknowledging that there are the positives there too. We're using a lot of real world examples, so not just psychologists from our ivory tower trying to explain to people what we think ADHD is all about. We're using real world experiences, so resources that are available online, with people explaining what ADHD is like. We're also trying to engage people by using different polls in Zoom to help them kind of reflect on the way that ADHD affects them and other issues. But using the poll, it's going to be anonymous, so nobody will ever see them, but see what any individual has said. But it allows them to kind of really understand the material and apply it to themselves. So here's an example of a poll that we'll be using, kind of considering really what the different types of challenges are and how they specifically affect that one person. We're going to be using lots of videos that really hopefully engage people and will break up the kind of monotony of having somebody just talking all the time. A lot of these materials we've downloaded from YouTube. How to ADHD is a brilliant resource that many people use and find very helpful. So here's just a little example of that.
ability to regulate attention is part of something called the executive function system. It's kind of like our brain's self-management system, what allows us to plan, prioritize, and sustain effort toward a goal, say making dinner, without getting sidetracked. It's what allows us to inhibit or not act on our impulses and ignore distractions so we can stay on task and switch when it's time to switch. In the ADHD brain, executive functions develop much more slowly than in neurotypical brains. And we have a deficit in the brain chemicals that help them function. So we usually know what to do and have the best intentions, but our executive function system isn't always developed or functioning well enough to effectively help us do it. And it's just as frustrating for us as it is for anyone else. Haley Melville explains it like this. Your brain is like a secretary, and you're the CEO in a meeting, doing a task. In a neurotypical brain, their secretary greets guests, potential distractions, lets them know that the CEO is in a meeting, and either encourages them to make an appointment or shows them the door. My secretary either lets everyone into the meeting, nor lets no one in, even if it's something important. Another executive function is working memory. That's our ability to temporarily hold information in our head so we can work with it. Like look at a recipe and then remember the steps while we cook. It's our brain's version of RAM. Everyone has a limited capacity of working memory, but it's often more limited in those with ADHD, which is one reason we might blurt out an answer before we forget it, or ask you to repeat what you just said. Timothy Warnke says, it's like my brain is a whiteboard and I have to write down everything that's happening right away, but I write kind of big, so pretty soon I have to erase a bunch of stuff to make more room. By the way, that's also why we tend to have trouble following multi-step directions. It's also why Post-it notes are helpful.
So that's a nice example of one of the tips that we'll be using. And hopefully that'll resonate with people as well, because this woman has ADHD and describes it.
The ability to regulate attention is part of something.
We're also using exercises for people to do while they're in the webinar. So they'll be filling in their workbook and then putting ideas that they've had in the chat function and that we can kind of discuss and go through. We're giving people lots of different resources that they might want to follow up with as well, I suppose, as part of the psychoeducation piece. So these can be online resources and web links to where they might be able to find them. We're evaluating this, this intervention by asking people to do pre and post questionnaires for the whole series, but also do polls at the end of each session just to find out how helpful things were, what suggestions they have for making changes, and what they really kind of gained from the sessions, which will allow us to kind of refine it in time. So where we're at the moment is we've developed all the materials, or rather I should say Christina Siri, the wonderful PhD student, has developed all the materials, and we're piloting them with people who have ADHD, who are then going to give us feedback after each session about what they really liked, what they thought should be different, in order to really refine it and make it suitable for the audience. And then in early 2022, we're going to be rolling it out in the webinar format through ADHD Ireland and evaluating it in full. So that is the kind of summary of what we've done and our UMAP programme, which we're really excited about, and I think it's going to be a great resource for us in Ireland. We're hoping to obviously publish the findings in due course, but also we've developed these materials and we hope that they may be useful for others in the future, so please do get in touch if you're interested in our resources. And thank you very much for listening.
Thank you, Dr. Bramham, for sharing your experience and your new plan of developing self-help. That was really interesting. Particularly in my clinic, we have colleagues who are interested in ACT, acceptance and commitment therapy. I would definitely take this with them. We may perhaps contact you in the future if we can design something similar to yours. I do hope it turns out really well for the ADHD sufferers. Okay. I'm not sure if there are any questions. Yes, there's one.
Hi, I'm Dr. Ayşe Sakallıkani. Thank you for your presentation. It was really comprehensive and impressive. I would like to ask several questions. It reminded me that the app looks like an agenda. Are you planning to add the application some reminders to do the tasks for people, but I'm not sure that does it work, whether it works or not, because people probably won't remember to check the app or obey the instructions. Thank you very much.
Yeah, good question. And I think that was something that we, there's like a group of us that are working very closely in the development of it. And that was something that we discussed. And it's not within the remit of the app that we're using anyways, unfortunately. But what we were conscious that we didn't want the app to be laborsome, that it was kind of something people could come to when they needed a few tricks or tips, but not something that they came to resent with it being a reminder tool. But what we do have within it is like a little My Planner section. So instead of reminders, there's a section for developing SMART goals, so specific, measurable, achievable, realistic and timeframe goals, and then also writing out their motivations for that. But that's not something that they'll be prompted to or reminded of, unfortunately. It would have been great to incorporate that, but it was kind of not going to be possible with the app framework.
Any other questions? Okay, I think it's the end of the day and people are tired. Thanks very much for your excellent presentations and contribution to the Congress.